Welcome to Matflix, video streaming from maternity experts. My name is Dr. Jenny Hall. I am the box set's curator at Matflix, a fellow of the Royal College of Midwives and a former editor of The Practicing Midwife. At Matflix, we bring together videos of talks from top maternity experts into box sets to support your continued professional development, study and revalidation. It is a perfect study accompaniment for midwives, maternity professionals, midwifery students and anyone thinking about a career in the maternity services. My job is bringing together the latest thinking area by area so you do not have to. Not only do you get the video of brilliant talks and relevant content in thematic box sets, you also get access to the audio version so you can listen on the commute or while you walk the dog. Plus links to the latest research in the relevant field, government policy documents, the presenter's PowerPoint and more besides. Sign up to Matflix now for the best video streaming from maternity experts.
These awards, as you know, are a celebration of achievement, effort, change, innovation, management, insight, and the many other traits necessary to sustain a proud profession like midwifery and consistent services in maternity.
We invite people to nominate a colleague or a student or a manager, whatever, where they think that person's a real trailblazer.
And it's really a celebration of all that's good in midwifery and maternity care.
They recognise individuals, they recognise teams, management and educators. Anyone who values excellence and makes improvements. They are essentially a celebration of all of your achievements. So, shall we get on with it? What you do with your day-to-day lives, I just admire you hugely. If you do want to nominate a colleague, a friend, maybe yourself, please speak to the organisers and visit the website, and I really hope that we'll see you at that.
Okay, now the first award is... What's
Nothing, I don't know.
We have had a 40% caesarean section rate in the National Maternity Hospital. That is major abdominal surgery.
Around 40,000 mums did not return to work in 2022. It's even more relevant if you're a mum who's experienced birth trauma.
We spend more money on litigation than we currently spend on the maternity services. It's bonkers.
It's in all of our interests, and particularly the government, to improve maternity services.
We can't achieve our mission unless we bring parents and professionals together.
A revolution needs to happen. We need to start working together.
I know it's a hard time, but for goodness sake, it's the best profession in the world.
Be proud to be midwives, be proud of the job that we do and continue to celebrate our successes.
Midwives make a difference to women every single day, and let's not lose that. It's more important than anything.
Welcome to Matflix, video streaming from maternity experts. My name is Dr. Jenny Hall. I am the box set's curator at Matflix, a fellow of the Royal College of Midwives and a former editor of The Practicing Midwife. At Matflix, we bring together videos of talks from top maternity experts into box sets to support your continued professional development, study and revalidation. It is a perfect study accompaniment for midwives, maternity professionals, midwifery students and anyone thinking about a career in the maternity services. My job is bringing together the latest thinking area by area so you do not have to. Not only do you get the video of brilliant talks and relevant content in thematic box sets, you also get access to the audio version, so you can listen on the commute or while you walk the dog. Plus links to the latest research in the relevant field, government policy documents, the presenter's PowerPoint, and more besides. Sign up to Matflix now for the best video streaming from maternity experts.
These awards, as you know, are a celebration of achievement, effort, change, innovation, management, insight, and the many other traits necessary to sustain a proud profession like midwifery and consistent services in maternity.
We invite people to nominate a colleague or a student or a manager, whatever, where they think that person's real trailblazers.
And it's really a celebration of all that's good in midwifery and maternity care.
They recognise individuals, they recognise teams, management and educators. Anyone who values excellence and makes improvements. They are essentially a celebration of all of your achievements. So, shall we get on with it? What you do with your day-to-day lives, I just admire you hugely. If you do want to nominate a colleague, a friend, maybe yourself, please speak to the organisers and visit the website, and I really hope that we'll see you at that.
Okay, now the first award is... What's
Nothing, I don't know.
We have had a 40% caesarean section rate in the National Maternity Hospital. That is major abdominal surgery.
Around 40,000 mums did not return to work in 2022. It's even more relevant if you're a mum who's experienced birth trauma.
We spend more money on litigation than we currently spend on the maternity services. It's bonkers.
That it's in all of our interests, and particularly the government, to improve maternity services.
We can't achieve our mission unless we bring parents and professionals together.
A revolution.
and welcome everybody to this week's Maternity and Midwifery Hour. We're now, Series 18 and Session 3. I can't believe it. My name's Sue MacDonald. I'm the curator for the Midwifery and Maternity Hour and the Midwifery and Maternity Festivals. And it's my pleasure to be chairing this session this evening. And tonight we're joined by one speaker, Keely Grindley, and I'm delighted that she's with us. So welcome, Keely. And what we have to do is put Keely on the spot and ask her to share a moment of the week with us. Welcome, Keely.
Hi, thanks for having me. Okay, moment of the week will be, it's not actually midwifery related, but my son, he's 8, he's been learning to play the guitar for the last few months, but gets very frustrated with himself that he can't actually, well, when I say he struggles with playing an actual tune. But he had his lesson this week, and it was time to practice, the dreaded time where he has to practice it. And he actually played me a nursery rhyme really well with no mistakes and sang it at the same time. So that was a real moment because he was really proud of himself.
And which nursery rhyme was it, Keely?
Mary had a little lamb.
Oh, sweet.
It was really cute. I was just expecting it to be another time where it's like, oh, he's getting really cross at himself, but he was really happy because he could hold the tune.
Oh, Keely, I bet you had a lump in your throat, didn't you?
I did. It was lovely. I was dead proud. So that was my moment of the week.
And I think that's, I have to say, you've gingered in me memories of me as a kid having to learn to play the piano. And I didn't understand you had to do practicing. I thought you could just start playing something.
That would be nice, wouldn't it?
And he's probably the same. He wants to sort of get there, and he's there.
That's it.
Fabulous.
Exactly.
Well, thank you so much, Keely, for sharing us. Now, we'd give Keely a few minutes now before her presentation, and just say another welcome to new people this evening. And I know we've got some new people who haven't been with the Maternity and Midwifery Hour before, so welcome to you. You may or may not know where we came from. And it sounds like a gestation or something, but we started the Maternity and Midwifery Hour in 2020, March 2020. So we're coming up for our 6th birthday. And it was really at the beginning of the COVID lockdown in the UK. And this was in response to knowing that midwives and student midwives and everybody actually in the maternity care, everyone in the health service actually was so focused on COVID-19 and caring for people at that point, changing services to make them as safe as possible for patients and staff. And we really felt that it was important that there was some sort of connection because we weren't allowed to go to study days or conferences or anything like face-to-face events. And we felt it was important to get that connection. So we started the maternity hour, just an hour a week, and we started off with sort of well-being and that sort of thing, and also a lot about COVID-19, which was very unknown at that time. You know, it was quite new and scary. And also sharing, we had midwife managers sharing what they were doing, midwife educators sharing what they were doing, and students and midwives all sharing. And it was an incredibly powerful time from that point of view. And we've carried on. We're not doing, obviously, so much on COVID now, but we are doing current issues. And it seems as though people still quite like the maternity hour, so we carried on. Now, I need to, also for the new people there, and it's lovely that you're here, don't panic if you have a power cut. Everything we do at the Maternity and Midwifery Forum, which is underpinning the maternity hour, is recorded. So if there's any problem, you can always catch up later. Also, this is really incredibly useful because I know you're going to find this evening really interesting and really quite challenging, I think. It's going to make you think, and it's going to make you want to share what you're learning. So you might want to watch it all over again. I hope you do. And you might want to share it with your colleagues. I hope you do, because that for me is the real good way of learning, because you can meet with your friends and your colleagues. You can talk about what you're learning. You can have a bit of a debate, bit of a discussion, and actually challenge yourselves to think. If you're one of the midwives looking at revalidation in this next year, very useful for your reflective discussion and that sort of thing. Also, it's very useful to understand the stresses within the maternity services and some of the changes we have to make as individuals to improve care for women and their babies and their families, really important. And I always think about this because this issue that we're especially looking at this evening is something that comes up in lots and lots of reports that we're not getting it right. So we really need to address it without feeling guilty, but with feeling strong and committed to change. So I'll get off my soapbox. Now, because everything's recorded and it's looked after in the Netflix sort of back catalogues, you can access a whole load of stuff. So if you're a student midwife, or you're midwife doing a project, you're doing a dissertation, any sort of study work, there is a whole back catalogue of delicious things that you can learn about. Health warning, and I've said this for the last couple of weeks, health warning, once you start watching these presentations, it's a little bit addictive, and you will find a couple of hours has gone and you've been listening and kind of absorbing a lot of what the speakers are saying. It's a really nice way of learning new things. But that's the health warning. Useful to access it. So check whether your institution or your trust has a subscription to Netflix, because then you can access it all free. Okay, and I'm going to say, and I say this quite often, but look after yourselves, because I know at the moment there's a lot of bugs going around. We're all short-staffed. It seems as though maternity and midwifery has been short-staffed forever, but we are short-staffed, and it's a time when people are having to work over the odds, and it's very tiring, and you need to care for yourselves and care for your other people around you. Make sure, someone's struggling, offer them a cup of tea or water, anything, keep them going. Now, we're coming up to the news bit. I haven't got a huge amount of news, really. There's a lot going on in the world. The world is going mad, and there's horrible news, and there's things that are quite relevant to this evening's session as well. And there's things that sort of remind us that the world it's not new that the world's been difficult to live in, because yesterday was Holocaust Memorial Day, and that was marked with the purple lighting on important buildings and candles lit in the windows to mark the loss of over 6 million people, mainly Jewish people, during the Second World War. But also other people were targeted at that point, and it's important. They always have said never again, and we know that is kind of tricky now, because there are dreadful things happening and things that aren't right. Bit of nice news now, just to lighten things. But I heard that pioneering midwife, and I think this is such a lovely, lovely thing to happen, Agnes Nisbet. And you may have heard her on radio. She did a little radio piece a few months back. She improved cares for mothers of stillborn babies, and she was honoured by the University of Leicester with the Doctor of Science Award. And this emerged from, in 1973, Agnes lost her baby through a stillbirth at Leicester Royal Infirmary, at a time when babies were kind of routinely taken away immediately after birth, so she didn't necessarily get to keep her baby with her or touch her or see her baby. And she set up the Born While Sleeping programme at the Leicester Royal, including a dedicated ward for mothers of stillborn babies to help other women in the same situation. And I thought that really underlined the power of things we can do as individuals. And it was a really lovely to kind of hear that she'd been honoured in that way. Now, we talked a little while ago about data brief on maternal mortality from the National Perinatal Epidemiology Unit. That's on your resources list. Again, I've kept it on there. And this was a sort of breakdown of some of the mortality rates. And it's very relevant to the session this evening, because though it had things like the thrombosis and thromboembolism being the leading cause of death, it also highlighted the inequalities that we have in the maternity services in the UK, including the threefold difference in maternal mortality rates for Black women compared to white women, and Asian women's risk of maternal death was also slightly higher compared to white women. And in 2019 and 2021, this was actually lowered a bit, so it's gone up a little bit, which is not good. And it also underlined that women in deprived areas continue to have a maternal mortality rate which was higher than you would expect as normal. So this evening, we're going to be looking at the impact of systemic racism, unconscious bias, and the disparities in maternal and perinatal outcomes for Black and brown women in comparison to their white counterparts. And this really is to help us look critically at ourselves and the care we provide to women and babies, and really address the whole issue of inequalities. And I'm so delighted that we're joined by Keely Grindley, who is the Equality, Diversity and Inclusion Lead. And she's going to be sharing some of her work. It has to be some, not everything, because there's a huge amount that she does. Where she's providing education to the maternity workforce and student midwives and anti-racist midwifery practice and racial inequalities. She qualified as a midwife 3 years ago, and she describes her current role as her dream job, which is lovely. I love that. She developed a strong interest in addressing health inequalities within her services after representing her trust at the Black Maternal Health Conference in 2024. She designed and delivered a training package focused on equity in maternity care for ethnic minority women. And this is now delivered to midwives and obstetric teams alongside her ongoing clinical practice. She's also been recognised, and she was nominated for the Rising Star Award. Wonderful. Of the Black Maternal Health Awards UK, which celebrate excellence in maternal health care, including care quality and access, maternal mental health, education, policy change, empowerment and community support. So I'm delighted Keely has come along this evening to share some of what she's doing with us this evening. So welcome, Keely. The screen is now yours.
Thank you so much. So hi, everybody. So I'm going to be speaking to you about racial disparities in maternity care in the UK. So this is about reflecting and sitting with our discomfort, because a lot of what I am going to say might make you feel a little bit uncomfortable, and that's okay. Please see that as a positive, because that's where change starts. Us being able to sit, feel a little bit uncomfortable, reflect, acknowledge, and move on. So what's the problem? So I'm sure some of you will be aware of some of these statistics. So Black women and birthing people in the UK are 2.9 times more likely to die in childbearing than their white counterparts. Those with Asian heritage in the UK are nearly 2 times more likely to die. Those of mixed race or mixed ethnicity are 1.3 times more likely to die in childbearing. So Black women and birthing people in the UK have a 40% increased risk of miscarriage. And Black babies are more than twice as likely to be stillborn than babies of white ethnicity, and have a 43% increased risk of neonatal death. The Office of National Statistics have categorically stated that this is actually inequity, in that babies from Black ethnic groups have the highest rates of stillbirths and infant deaths, with babies from Asian ethnic groups consistently being the second highest. And Black neonatal deaths were rising on the last Embrace report before the last one, if that makes sense. And now Asian neonatal deaths are currently on the rise. So contributing factors, what are they? You'll probably have some ideas of what they are. And this list is definitely not exhaustive. But we've got things like inequitable services, stereotyping, bias, lack of exposure to cultural diversity, lack of knowledge around what anti-racism actually is and what anti-racist care looks like, inequitable policy or guidelines, so policy and guidelines that aren't necessarily made with everybody in mind, barriers to accessing care, lack of training in assessing Black and brown skin tones, language barriers and low compliance of professional interpreter use, and systemic or institutional racism. So the ones that I've put in bold there, I'm going to hope that I've got enough time to speak to you about today. So, stereotyping, what is it? So it's making oversimplified assumptions or judgments about people based on their protected characteristics. So for example, ethnicity, citizenship, LGBTQ+, religion. It's an act that can be done unconsciously, which is what we call unconscious bias. And it can be unconscious bias the first couple of times, but if that continues, that's a conscious decision, and there is such thing as conscious bias too. So I've just put a couple of examples there of kind of common stereotypes. So this woman here, I am Indian, but I don't prefer chilies in my food. Or I'm from the Irish traveller community and I live in a house, not a caravan. It's easy to stereotype people unconsciously, and we're all guilty of doing it. So it's about acknowledging that and checking your bias and your thoughts at all times, especially when you've got people from ethnic minorities that you're caring for and you care. So formation of stereotypes then, socialization. So you've got primary socialization when you're kind of a baby and a toddler at home, and you're getting to know and understand the views of those around you within your family. And you've also got secondary socialization, which is when you go out to school, high school, college, etc. Limited exposure, it might be that you have lived, grow up and now work in an area that is not diverse at all. You might not have many black and brown people in your care at all. Confirmation bias, which is kind of a going out of your way to favour people that look and think like you. Yeah. Prejudice, preconceived ideas and feelings and opinions on people, which isn't based on any fact at all. In-group and out-group bias, we all have that. We'll talk about that in a little bit. Representation in media and historical events and systemic oppression. So there are many common Black stereotypes. If there's anybody that's of Black heritage who's sat on this call today, I know that loads will spring to mind straight away. Because people of colour often grow up with many labels thrown at them, and it just becomes everyday life. So a few to mention are aggressive, difficult, masculine, argumentative, loud, strong, and angry. Now, some of you might have heard this in passing. Some of you may not have heard about it, but what I need you to sit with is if you've not heard these, it doesn't mean that they don't exist. So, how can stereotyping impact maternity care for the global majority? And when I say the global majority, I mean anybody that isn't white. So there's much research out there, and the running themes throughout the research on Black and brown maternal health is that global majority families often aren't listened to. So that should be an easy fix. Yeah, their concerns are often disregarded. That should be an easy fix. And care is often based off assumptions that we make, whether that's unconscious or conscious. And what I've highlighted in red there, one of the main running themes throughout the research is inadequate analgesia offerings in labour. Analgesia is pain relief. So just to talk about the stereotypes there, you can see at the bottom, strong. That's a very common stereotype for the Black woman. So if you think about how that, if we're unconsciously, for example, stereotyping a Black woman of maybe African heritage who has had 4 children before, she's done it 4 times before, she's strong, she's got this handled. Are we offering her adequate pain relief in labour? Are we necessarily going to give her the in-depth, detailed breastfeeding support that she may need? Stereotyping really does impact care in a negative way. So here's a case study. This person had a category 1 emergency C-section, and she felt unwell post-section whilst admitted. She knew she had a significant risk of a DVT, but she wasn't given blood thinners at the time. She didn't feel heard when she was in excruciating pain and asking for help, and she continued to ask about the blood thinners. Her health deteriorated when she started to uncontrollably cough, and she was unable to catch her breath. So due to the coughing, her scar ruptured and she was taken for surgery. Post-second surgery, she pressed for a scan of her lungs and to be put on blood thinners. And she's quoted there, over and over again, "I wasn't listened to." And another quote from her healthcare provider at the time, "The meds you've been taking are making you crazy." So she had to continuously persist and advocate for herself until the doctor finally agreed to a CAT scan. And the CAT scan revealed a PE and multiple other clots which needed immediate emergency treatment. This person was in fact Serena Williams, who is, I'm sure you all recognise, as a world famous tennis star. And yes, it's an American case study, but the disparities are very, very similar over there. And it's just a clear example, really, that no matter someone's status, fortune, education, these biases exist and affect all black and brown people and birthing people, women and birthing people, sorry. It doesn't matter who you are. This is sadly what happens. So let me know, well, you can't let me know, but have a think about whether these statements are true or false, and if it's anything that you've heard in practice before. So black people have physically thicker skin. They're harder to cannulate. They're harder to take blood from, and they feel less pain. There was a study with 222 junior and senior doctors, and 84% of them believed that black people have physically thicker skin than white people and less sensitive nerve endings. A belief on their admission would have influenced decisions made regarding medications and pain relief prescribed for black people in their care. So there's a study that you can find. I'm going to give you a QR code to my Padlet with all the resources, and you can view the study. That this has been completely refuted, okay? That's just a quote from the study there. Obviously, there's different things that can impact people's skin thickness or thinness, like exposure to the sun, disease, and age, but melanin definitely isn't one of them. So as this isn't, these statements here are not true in any which way. Where has this come from? Why are highly trained medical professionals often having these thoughts about black people having physically thicker skin and less sensitive nerve endings, which is impacting on care? So myths about physical racial differences and dehumanization were used to justify slavery hundreds of years ago and are still believed to this day. So to give you a little bit of context on this, we know that slavery happened a few hundred years ago, and the different African countries and different Caribbean islands, families were torn apart, they were packed on ships, and they were sent in opposite directions across the Atlantic to be enslaved. Fact, okay? They had to have a way in which they could get away with doing that, and that was dehumanization of black bodies and black people. They have less sensitive nerve endings, so they're less likely to feel the whips on the back. They have physically thicker skin, they're stronger, they're less capable of feeling pain. Okay, so if we're in 2026 and often this is still a belief in healthcare, we still have a very, very big problem. So barriers to accessing care. Before I just move on to that, sorry, if you ever hear that in practice, do you want me to go and cannulate the woman in room A because she's black? Yeah, which many people hear on a regular basis working in maternity. Just ask the question, oh really, where did you hear about that? And often you can see their minds ticking because they have not learned that in medical school, okay? And if you professionally challenging comments like that is where change starts, right? Because bias like that thrives in silence. And so the cycle continues and continues and continues. New medical doctors coming up into the system, new student midwives coming up into the system and hearing these comments, and then they believe it. And this is a clear example of deeply ingrained racism, okay? So always professionally challenged because it's not true. And, doctors and midwives, we're all evidence-based. It's evidence-based practice, right? If you ask for the evidence and they're unable to give it to you, that's a really positive moment and usually would spur a really positive conversation. So barriers to accessing care. There's many barriers to accessing care for everyone from all walks of life, such as these on the screen, general and digital poverty, transport, childcare issues, lack of accessible information, inaccessible environments, language barriers. We've all come across all of these. But speaking about Black and Brown communities today, a really big barrier to accessing care is distrust in the NHS, distrust in doctors, nurses, midwives. And what you've also got to remember as well, maternity specific, there's been a spotlight shone upon Black maternal health disparities these last few years. It was even a storyline in Coronation Street. Black women and birthing people are becoming more and more well-read on this topic and are coming in to access maternity services scared of becoming a statistic, not trusting you. So what do you do to break down those barriers? Because we need to make them feel safe, right? So there are many examples in history which caused harm to individuals in the past, the effects of which are still felt by populations today, causing medical distrust and vaccine hesitancy in some Black and brown communities. So just to give you a little bit of context, I'm just going to whiz through a few examples for you. Some of you might know this picture, and I would imagine that most of you know who Dr. Sims is. He discovered a way to cure obstetric fistula by experimenting and operating on enslaved Black women without anaesthesia. Once his technique was perfected, he employed anaesthesia for his white patients. Sims believed that Black people didn't feel pain in the same way that white people did. So referring back to what we said about Black people, the dehumanization of Black people having physically thicker skin and less sensitive nerve endings, this was also during slavery. The Sims speculum is still used to this day. The stereotype regarding Black strength and a reduced requirement for pain relief and anaesthesia does persist today in Western medicine. UK Black maternal health disparity research evidences inadequate offerings of pain relief for Black women and birthing people in labour, and that's across the board. It's not just maternity care that this happens in. The Tuskegee syphilis study, so this was a study, I think it was in the 50s, where in America, where Black African American men were put into a study where they weren't treated for syphilis without knowing that they actually had syphilis in the first place. So the impact of that was over 100 lives lost and a global distrust in healthcare healthcare institutions with Black community. The Coventry Chapati experiment, excuse me, this was only in the 60s in Coventry, where women and birthing people were registered onto this this study where they were to eat chapati, sorry, which is an Indian kind of bread, right? Without knowing that there was radioactive substances inside them. It completely went against all, ethical ruling. And this is something that is very much remembered amongst, global majority communities, specifically Asian communities. And man-made famines in India and the type 2 diabetes epidemic. You've got the resources on the Padlet, which you can read up on these in detail. But basically, throughout colonial rule, where places and populations were put into famine, and that was man-made famine. So at one point they had food in abundance, but then had none. Over time, it's come out that there is a thrifty genotype, which they are linking now to predisposition to type 2 diabetes. So if you think about the man-made famines throughout colonialism, specifically in places in Asia and in India, who is more likely, who's most at risk of getting type 2 diabetes? South Asian people, Caribbean people, African people. The same with gestational diabetes, right? It's a risk factor. We're going to make sure that anybody basically who is Black and brown has the GTT, just in case they get gestational diabetes in pregnancy. And it's something now they're linking to colonialism, which is, man-made famine turning into kind of man-made predisposition to disease. So the APGAR score, we're going to talk a bit about institutionalized racism. So the APGAR score, you all know what the APGAR score is. It's a biased assessment, though, that assesses if babies are well or not at birth. And for anyone listening that isn't sure about what it is, it's kind of a scoring system. And we score against things like reflexes and tone. And one of the things that we score on is colour. And our options are pink for a well baby, pale or blue for an unwell baby. These options clearly disregard babies with black or brown skin, as black and brown babies are never pink. You're not always going to be pale, and they're not always going to turn blue. So it's language and practice based on the white normative standard. It raises concerns as well around clinical accuracy of assessment when applied to global majority babies. This is, and we shouldn't be shy to say it, institutionalized racism. Why? Because it's a tool that assesses whether a white baby is well or not at birth. So I can never say this word, so I'm going to say pulse ox so I don't embarrass myself. So during COVID, it was found that pulse ox equipment overestimated oxygen saturations in people with black or brown skin. So it meant that global majority patients were more hypoxic than the machines suggested. And it was evidenced in the New England Journal of Medicine in a study called Racial Bias in Pulse Ox Measurement. The study found that black patients were nearly 3 times more likely than white patients to have occult hypoxemia that was not detected by the pulse ox. Again, this is institutionalized racism. Why? Because it's equipment that was tested and calibrated primarily on white populations, and regulators approved them anyway. This led to clinical decisions based on biased data, which then led to black and brown people dying of COVID at disproportionate rates in comparison to white people. The NHS has acknowledged the problem, but most trusts still use the standard pulse ox, which are proven to be inaccurate in darker skin tones. We're still using those. We're still using them for neonates. We're still using them for pediatrics, and we're still using them for adults. Midwifery education. So the NHS Race and Health Observatory reported that teaching of clinical assessment on the midwifery curriculum and beyond is usually based on white skin as the normative standard. So, for example, learning resources, textbooks, and simulations often centre in white bodies. The assessment of illness is often taught through skin colour changes that are primarily observable on white skin. This raises concerns around clinical accuracy when assessing black and brown women, birthing people, and babies. The MNSI in 2023, which is an external body who investigates when a woman or birthing person or baby dies, they reported an uptick in black and brown babies being diagnosed with jaundice catastrophically late due to visual signs not being detected. Again, this is institutionalized racism. Why is it? So non-decolonized midwifery education produces clinicians who are better equipped to assess and diagnose white patients, whilst grey areas remain for everyone else. Grey areas often lead to mistakes, delays, and ultimately poor outcomes. So obviously, change is here, a very high level, and lots of it comes down to funding, senior leadership, top level. However, we can all make a difference here, okay? The APGAR score, we shouldn't be recording that a baby is pink. We should be looking for signs of perfusion, yeah? We should be writing whether the baby is well perfused or not. I know your hands are often tied, depending what system you use to record on. However, if you've still got handwritten notes, you can longhand it. If you have to put it on a drop-down box, if there's pink, if there's a space at any point where you can write free text, I would write that the baby is well perfused, because it's about coming away from this language that is completely inequitable. Pulse ox, you just need to bear that in mind. Sadly, for our black and brown babies and adults, we have to work with the best of what we've got, basically. We don't have that privilege as black and brown people, okay? That is a white privilege that, white patients don't need to be worrying about that. It's accurate. Just a disclaimer, this is not to say don't use the pulse ox. Use it always, okay? But be considerate of the whole clinical picture, okay? Bearing in mind that, you know, if someone is cyanosed, for an example, who is black, they're not necessarily going to turn blue around the mouth or in the face, okay? So it's about thinking of the whole clinical picture, making sure you use the equipment that we've got, but also if someone is cyanosed and they're black, check the nail beds because they will often turn blue. So midwifery education, if you're a student midwife listening at the moment, you know, have a think about what your curriculum looks like. And if there isn't any equitable care or anything on disparities or anything on anti-racism, it should be a whole module at least. But if it isn't, you should be asking the questions why. Anti-racism. Anti-racism is an active and intentional commitment to challenging, dismantling and eradicating racism in all of its forms, both at an individual and systemic level. It includes joining global majority people and getting out of your own comfort zone when you see, sense or feel racism in action. But you need to remember that racism is actually a spectrum and we all sit somewhere on it. People often make the mistake of saying, I don't, you know, I don't say racial slurs. I don't refuse to care for Black people. Therefore, I'm not racist. Okay. But it's a spectrum and it's not just as simple as that. So when it comes to racism, people are often more invested in defending intent than actually addressing the harm that's been caused. Harm exists even without racist intent, and we all sit somewhere on the spectrum. Not going to have time to go into it in great detail. However, maybe I'll be back one day and we can spend more time on this. But on the left side of your screen, you can see overt racism, okay? Overt racism is racial slurs or maternity specific, refusing to care for a Black birthing person because they're Black and not being ashamed to say so. I'd like to think none of us are like that, okay? But that's an example of overt racism. But just because you're not overtly racist doesn't mean you don't sit somewhere on this spectrum. And as we move across to the right, that's when we start to get to the good stuff, okay? So covertly racist, it's just less obvious racism that, you know, is rife, and it's often more hurtful because it's harder to prove. It's subtle. Microaggressions are kind of everyday comments or expressions from people, which are just kind of the everyday. For example, you know, an international midwife, an internationally trained midwife from South Africa might be told by another midwife, you're really, you know, you're really well spoken for an African woman. Yeah, you know, you've got really good training. You've got really good midwifery training coming from South Africa. I wouldn't have expected that. Yeah, comments that if you were to escalate could potentially come back as, well, it's not racist though. She didn't mean it like that. Yeah, microaggressions are really, really impactful because they're things that happen every day. Othering, pretty self-explanatory. Something to think about if you see the umbrella BAME, which stands for Black and Minority Ethnic. That's a very othering term. That's basically saying anybody that's not white is just going to be lumped under this umbrella. Yeah, that's othering. Treating difference as a problem, it's quite self-explanatory. Stereotyping we've discussed. Prejudice, conscious bias, unconscious bias, defensiveness. Now, if you were to, some of you might have been on one of my kind of half-day sessions before, where we really go into the nitty-gritty, and the natural feeling sometimes to some of these topics is to feel defensive, right? Because sometimes something might come up that might have been something that you've done or said or thought before, but there's no judgment. And it's okay to feel defensive, right? But what isn't okay is to let that take away from the important topic at hand that we're discussing. Does that make sense? So it's about sitting with your defensiveness and just reflecting a little bit. Minimization of issues. You know, they didn't mean it like that. That's not what they meant. You shouldn't feel this triggered by that. Yeah, really harmful. Silence in inaction is really harmful too. We should all be being active bystanders, right? If we're seeing, you know, in maternity care, a decision made that's clearly been influenced by bias, intentional or not, Silence allows that to thrive. Yeah. Having courageous conversation is where change starts. Yeah. It's about taking ourselves out of our comfort zone. Remembering as well that it's hard for us to come out of our comfort zone, right? Especially at work. I get it. But what we've got to remember is Black and brown women and birthing people accessing maternity services are a whole lot more uncomfortable. Yeah. So it's about joining them in that and trying to enact change. It's not enough to just not be racist anymore. Yeah. Not being racist, but not doing anything about it doesn't count. We need to be working towards being anti-racist. So moving into the good things now, awareness. So you're here in tonight's session, which is always really positive, by the way. It's not mandatory that you have to be here tonight, and you knew it was going to be uncomfortable. So that's really, really positive. You want to be more aware. That's why you're here. Yeah. And awareness leads to accountability then. Yeah. Taking on mistakes that you may have made, positively taking accountability for that and learning and moving forward. That's all we can ask from you. But it's also about professionally holding others to account too. Allyship, and I should have put active allyship there. It's, being an active ally always, okay? And that means, being an active bystander, getting out of your comfort zone, standing against what is wrong and standing up for what's right. And obviously then anti-racist. So this is the last slide now. Hopefully I've got some time. So in terms of anti-racism, then you've got the fear zone, the learning zone, and the growth zone here. So if we make this midwifery specific, some of you might be in the fear zone, and that's okay. There's no judgment of where anyone is on their journey, okay? So you might deny that racism is a problem in society or contributes to the racial disparities that we see in maternity. That might be something that you cannot accept at the minute, and that's fair, okay? Striving to be comfortable. So seeing that Midwifery Hour are putting on this meeting tonight, not coming on it because it's going to make you feel uncomfortable. That's fair, okay? Working towards being anti-racist would be putting yourself into that situation to learn. If you're in the learning zone, it might be that you seek out questions that make you uncomfortable. Yeah. And recognizing that racism is a present and current problem, but understanding your own privilege in ignoring racism. That's a big one, right? Because that is a privilege. Black and brown people can't ignore racism. So it's about joining them in not ignoring it. Yeah. And holding professionally and politely holding people to account. Because what we need to remember as well is racism is rife within all institutions, right? NHS is an institution, universities are an institution. And at the moment, in the current climate, it's getting worse, okay? So it's about understanding that you can be privileged and ignore it, or you can make a stand and join people to try and collectively make a change. Educating yourself about race and structural racism. So that spectrum there was a really quick whistle-stop tour. If you had me for longer, I'd be talking about that really in depth. But go away and have a look at critical race theory and things like that, and really understand about race and about racism, yeah, because that's the only way you're going to be able to become anti-racist, with that understanding and knowledge. And being vulnerable about your biases and knowledge gaps. I have bias as a mixed race person. My mum's white, my dad's black. I have bias, yeah. I will naturally have bias about people who aren't necessarily like me, yeah. Whether it's about looks, whether it's about lived experience, different backgrounds, we're all guilty of that. And that might be an uncomfortable thing to admit, but we don't change anything until we do admit that, okay? So finally, the growth zone, which I reckon loads of you will be on, being on this call tonight. You're sitting with your discomfort. That's growth, yeah? Sorry, I've got a really bad chest. Promoting and advocating for policies and leaders that are anti-racist. Yeah, so it's, higher level stuff now if we were to make this maternity specific. I know that as an EDI midwife, I don't know if you've heard of the RES data, WRES, Workforce Race Equality Standard, and every NHS trust has one of those, and it's an annual survey and report that looks at the treatment of Black and brown staff in the NHS. The findings year by year from that RES data evidences that Black and brown people find it are very less likely to move up the bands past a band 5, 6. And when you get, band 7, band 8, you're having less Black and brown faces who are sitting in those positions. So when I, in my role, being aware of that, often bring people to a seat at the table to get different mentoring, to get exposure to different meetings, etc., and to help them kind of bulk out their CV a little bit when they're less likely to be put in those spaces to get those opportunities. That's anti-racist, yeah? Teaching others how racism harms our profession. So having those conversations, if you're a community midwife, you're in the staff room, with the other community midwives, having those conversations that you wouldn't necessarily be in tune to having before, yeah? So maybe tonight's chat can make you go out and do that tomorrow. And not letting mistakes deter you from being better in the future. Yeah, it might be, you've made a mistake somewhere, you feel like you might have caused offence somewhere unintentionally. Don't let that deter you from doing better in the future. You're not going to be judged on past mistakes. We all make mistakes. Yeah, it's about what we do with that moving forward. It's really common, with African sounding names as an example, or not even African, just a name to somebody who's not necessarily English, which looks long and really tricky to say. Yeah, often people will just not say the name at all, or they'll shorten it and change it into something that's just then not their name, which is really offensive. This comes up in all of the sessions that I do, and people will admit I've done that, but there's no judgment there. We don't go out of our way to hurt people's feelings. That comes from a place of just not wanting to offend most of the time. But don't let that deter you from doing better next time. Yeah. And top tip is just ask the person how you say their name. And if you get it wrong, apologise, ask again and try again. It feels really, really quick that I'm used to presenting in at least half a day. With obviously, it's just about raising awareness tonight and just about getting the message across. This is an emergency. Yeah, Black and brown women and birthing people and their babies are dying, significant disproportionate rates to the white counterparts. And you should all see that as an emergency, and we can all do our bit to make a change. So that QR code there, if you want to scan it, takes you to my Padlet, where you can read lots of different resources and articles and things to help with your learning. And you can get in touch with me on the email address there or on the Instagram handles there. My inbox is always open. If you had a question or just wanted to have a chat about something you struggled with at work or whatever and wanted to gain some guidance, you can always come to me, and I'll always try and help you where I can. But thank you very much for having me.
Thank you, Keely. I suspect there's going to be people sending you emails even as we speak. Thank you. That was really, well, I'd say uncomfortable. It wasn't quite uncomfortable, but it's got uncomfortableness. And I like the way you did say sitting with discomfort, because I think it's important that we acknowledge. I think I've sort of jotted down things on my little notes, and I was thinking about, it's very easy to feel guilty about things in the past. Yeah. And when you were presenting, the Tuskegee study I knew about, that was just horrendous what was done to those men and their families and the children. And it was in the 1950s, which is not that long ago. Exactly. So I didn't know about the others, but you kind of think, you start feeling guilty all the way through, and we need to move a bit beyond that. And I think you talking about, even something simple like apologizing when you get a name wrong, for example. And when you were talking about names, I'm just waiting for some questions to come through. By the way, dear audience, Keely's very happy to take some questions, even little tiddy ones or big ones. I think the shortening of names was really interesting too, as you're coming to the end, because I noticed that many people, black and brown people who have got complicated names, or for us, or for me, they might be complicated. Sometimes they're not. They shorten them themselves. So they've almost done it themselves to kind of help us out, which
for
feels,
our benefit.
yes, and it feels a bit weird. I mean, I know one practitioner who shortened his name, and I actually find it difficult to find out what his name is because he shortened it, and that's a bit sad.
Yeah, it is. Yeah, and often people who families who come over from different countries in Africa, as an example, will give their children their African name, but also give them their English name. And that's to give their children better life prospects in England, because it's been evidenced that if you have an African sounding name, you're less likely to get a job in different institutions and organisations in the UK. So yeah, it's often for our benefit when they shorten it to something else.
Yeah, it's quite uncomfortable.
Yeah.
Anyway, and we've got some thanks, lots of comments. I know that you all the audience have been talking away, which is lovely. And we've got lots of thanks, and we've got now Tracy Kafaki says, hi Tracy. The University of Salford has just launched its Maternity in Colour project in partnership with the University of Manchester NHS Foundation Trust to improve maternity care for women, birthing people and families from diverse backgrounds. The project is to help students and other healthcare providers recognise pregnancy, birth, postnatal and newborn conditions on darker skin tones. Well, that's fantastic.
Brilliant. Really positive.
It's really good these sort of things are happening, and as many of you will know, as an editor of the May's Midwifery, we did have quite a lot of problems finding images in pregnancy and childbirth, even babies sometimes in colour, in black, in brown babies, and it was very difficult. I mean, we managed. But we've still got a bit of a way to go. So I'm really pleased that there's projects like this going on, Tracy. So thank you for letting us know. And hopefully what we should be doing as midwives is maybe seeking out pictures and images from our patients and clients, if obviously with consent, to get images increased and shared, because that's really important, especially with the APGAR score. And thank you, Keely, you explained that so beautifully. It was wonderful. Thank you. And we've got some more for you, Keely. Now, forgive me, audience, I have to go to my other screen to get your comments that are coming through. So we've got Teresa saying thank you, Keely. We've got Shasta saying thank you, eye opener. Very much so. Diane Garland, hi Diane, saying wonderful thanks. Philippa, this one's good. Keely is amazing and has been an amazing support for me recently. Fantastic. Thank you, Philippa. And Lindsay says, hi Lindsay, says, thanks, Keely. We loved having you in Edinburgh. You've been travelling about, Keely. I can see. And we've got Abigail Lacey. Hi, Abigail, who says, thank you so much, Keely. Philandra Costello. Thank you, Keely. Absolutely brilliant, of course. Tracy Kafaki. Thanks, Keely. That was very informative and gave a great insight to a huge topic we should all be more mindful of. Thank you for that, Tracy. That was really good. And Samantha Brain. Thank you so much, Keely. You're an incredible educator. I think Keely's going to be blushing. She's going to be blushing. Yeah. And Laura saying, hi, Laura saying, thank you, Keely. That was wonderful. And then Felicia Pink. Hi, Felicia says, very insightful and highlights just how much change still needs to happen. Absolutely. And then Emma Bliss Harding, oh, it's moved along. Sorry. So happy I saw this and jumped on great insight into the training that I hope I can get organised with you very soon. I'm still struggling to pin down timetables at the uni. Good. Okay.
No worries.
Well, good luck with that. That's fantastic. And then Emma, we've got a question. Thank you, Emma, for this question. Do you see a future including this level of training within obstetric mandatory training?
In obstetric training?
Yes, well, that's what I think, because to be fair, I think it is coming into midwifery, but it might be useful in terms of obstetric. Do you have obstetric colleagues with you in your training?
Yes. So I think anywhere, because the EDI midwife role is becoming more common now, but I still think there's only around 8 of us in the UK at the minute where it's just our sole responsibility. You have kind of consultant midwives and other roles who have it as an add-on. But I think anywhere who has specifically an EDI midwifery role, it's the whole workforce, the whole maternity workforce that receives the mandatory training. It just needs to be mandatory training on the degree, whether that's at medical school or midwifery degrees. So you're coming out, culturally educated as opposed to culturally trained because you've just maybe had 2 hours in 3 years, I do see a future in with that happening. Not yet. I think it will take a while for it to catch on everywhere. Change is being made slowly, a bit too slow. But change is change, so we have to look at the positives.
And you really want it threading all the way through programs, not just as a 2-hour event.
Exactly.
It's our clientele and it's us as well.
Exactly.
That's fabulous. Okay. And another question from Leanne. Hi, Leanne, who says, "Hi, Keely. Are there any plans for change for non-English speaking families?"
There's lots of work that's ongoing nationally, really. It's language barriers. It's just a huge risk in and of itself. And in my view, many of the professional interpretation services that are available for us to use as midwives aren't fit for purpose. I'm not speaking for all of them, but we only have access to what we have access to. And if there's not enough interpreters and it's long wait times and you're not able to get in touch with, the dialect that you need, for example, it's really, really difficult. I think the current maternity crisis in terms of, being overstretched, not enough midwives, etc., definitely contributes to that. If you've got an overrun clinic with 20 minutes per antenatal appointment and you're already running behind and the next 3 people that you're about to see are non-English speaking and you can't get in touch with an interpreter each time, it's really, really difficult for midwives. But we've got to remember that's really, really difficult for the person on the receiving end who has no idea what you're saying when you talk to them in English. Compliance with professional interpreters is not great across the board. But there is, NHS England are putting work into that. So watch this space. Hopefully that's gonna change.
Thank you for that. Okay. I've got more comments now. I've got Natalie who's saying, "Hi, Natalie," who says, "You've shown how much we need to make the change from the ground up. So important." Thank you, Natalie. And Lindsay says, "Nothing can change until this training is mandatory." 100%. The people can come to these talks to forward their own learning and not necessarily the ones who need to hear this. That is true, Lindsay. That is a good point.
I agree.
And then Maxine, agree it should be mandatory. We need to continue to lobby the NMC standards for proficiencies as well.
Yeah, really good point.
Okay. And then Felicia Pink again. I'm at Northampton University in our cultural competency module. This is discussed. However, having it as a standalone module will make it a broader impact and promote real change. A day or two, a week or two is not really enough to embed this training. Well, that's true, because it's not just, of course, it's not just about training, because we can be trained to do things like little automatons, do this, that, and the other. The changes in our minds, which is a much trickier thing, and it's in our attitudes and our hearts about how we're approaching people. And you can't hide, if you have a racist approach, you can't kind of hide it because it'll pop out somewhere. We need to kind of address this in a real deep way. And I'm very conscious of that. And thank you so much, Keely, for coming to talk to us. I think I think it's been a really fascinating session, and it is uncomfortable for all of us, I'm sure, and it's people in guilt and how on earth do we start on this journey? And I love the fact, Keely, you talked about the journey, because I think it really is, because we have to move along that little continuum to get to where we need to be.
Yeah.
Because we'll grow as people as well, and it's important to do that. And I think we'll have to have Keely back. And you can all vote. You can all vote on the chat box, because I have to, as I always say, this hour of the week goes the fastest of any other hour in the week, and I know we have to bring it to a close. And I want to just say a big thank you to Keely. I'm also going to thank Angela, who's in the background, making sure this is all being beautifully recorded, so you have access to it. And now this is going to come out at 6 o'clock in the morning on Friday for those of you who like a nice podcast. And also it'll come out as a whole production next Thursday in the newsletter. So you do access it, watch it again, maybe get a group of your colleagues together, watch it, have a chat, ask what the problems are, where they're going, what can you do about it locally, and even, the sort of dealing from, the chat. I think that bit about challenging with the evidence was lovely. About the if people are difficult to cannulate or take blood from, what's that based on? What's your evidence?
It's really fun to do that. Just when you see them, like, it's fun.
No, that's the thing to do. That's the thing to do.
Yeah.
So thank you for that. Also, now next week we've got an update on the work of the NHS Resolutions Early Notification Scheme with Annette Anderson, Head of Early Notification, Lynn Tilley, Early Notification Regional Lead, Kelly Inglis, yes, National Midwifery Clinical Fellow, and Liz Pells, Early Notification Family Liaison. So that's going to be very useful for understanding about the NHS Resolution Early Notification Scheme. Now, remember the London Festival's on the 11th of February. There's still 1 or 2 places if you haven't booked for that. And that's in London. Did I say London? I think I did. And I just want to say a big thank you to our audience. You've really engaged with this fantastically. Get out there and share the word. Get out there and talk and think about the issues that Keely's raised this evening. Hopefully we'll see you next week. And in the meantime, take care of yourselves, and thank you again.
Thanks.
We have had a 40% caesarean section rate in the National Maternity Hospital. That is major abdominal surgery.
Around 40,000 mums did not return to work in 2022. It's even more relevant if you're a mum who's experienced birth trauma.
We spend more money on litigation than we currently spend on the maternity services. It's bonkers.
It's in all of our interests, and particularly the government, to improve maternity services.
We can't achieve our mission unless we bring parents and professionals together.
A revolution needs to happen. We need to start working together.
I know it's a hard time, but for goodness sake, it's the best profession in the world.
Be proud to be midwives, be proud of the job that we do, and continue to celebrate our successes.
Midwives make a difference to women every single day, and let's not lose that. It's more important than anything.